Morning, morning, everybody. Hope you're well. Just pop a message in the chat. Just make sure everything is working. Looks as if everything is good my end, so we'll get going. Welcome back. Had a bit of a break last week because of the bank holiday. I think we've got another one coming up in a couple of weeks as well. Yeah, we should hopefully. Good morning, Martin. Morning. Hopefully, we should finish off the hip and pelvis over the next couple of weeks. I don't think we'll do it today. We'll probably do it by next week, and then we'll be moving up again, starting on a new region of the body. And because we're getting closer to the spine and the spinal cord, we'll do a session on. We did a session last year, I think it was, on disc herniations and what they are and how it affects things. So I'll do an updated version of that as well. Good morning, Penny. Good morning. So that's the plan as we move up. And if there's anything in particular, because obviously we've added in a bit of pathology to the regions as well. So we've looked at some bony pathology of the hip, some soft tissue pathology of the hip, and then in particular tendinopathies. What tendinopathies are, obviously they apply to anywhere in the body, and it's a similar kind of process. So once you know it in one place, and then you can apply that to other areas. But the thing is with tendinopathies, they're very common in the lower limb, so that's why we've covered it on these sessions. Cool, right, let's get going then. So this is where we finished off last time. We were on the obturator nerve, and if this is one of your first sessions, I know we've had a couple of new people join the group recently. Welcome, first of all. This session is going to be pretty hard, and it's because the way that we do it is we kind of layer in information step by step, and each region takes around about 6 or 8 weeks. So we're nearing that kind of 2 months on the hip and pelvis. And so if you're new-ish to anatomy and you've not really heard of any of these terms before, you're thinking, bloomin' heck, what's going on here? Then we explain it all in the earlier videos. So we start off with the bony anatomy first, and then add in all the different layers of tissue. So these are the final layers. Okay, so if this is a first session for you and you've not really covered anatomy before, have a look back at some of the older videos. So this is video number 164, episode 164. So I think might have been mid 150s where we started the hip and the pelvis. So have a look, have a search back through the Facebook group and find those videos, and then you can watch them, or you just start afresh when we get to the lumbar spine. Okay, and then that will go through all of the layers. So yeah, if you're thinking this is difficult, it's because it is. And especially the nerves as well, because we get a lot of people doing soft tissue courses, health and fitness courses, some on degree programs where you will cover the nervous system in a fair bit of depth, but on usual kind of sports massage, sports therapy courses, you don't really cover the nervous system or the blood supply. It's all to do with muscles and tendons and the connective tissue. So this will be something that will be completely new to some of you. So yeah, but make sure that you have a look at the previous video so it doesn't freak you out. Okay, so obturator then. Let's get going. So we've got again we did a bit of an intro in this the last time we broadcast. So we've got obturator, which means to close, and there's an area. Let me just grab the spine. Hold on. There's an area of your pelvis. So this area here, where that hole is, that's called the obturator foramen or obturator hole, and everything is kind of linked around that area. So all the muscles are supplied by the obturator nerve, which we'll have a look at in a second. the muscles around that region. So you're looking at the adductor muscles, the adductors, and because all of those muscles close the legs, and obturator means to close. Okay, so everything around that area is named obturator. So that's I think once I started to get my head around that, when I first started learning anatomy, I could then divide the body up into sections. And the obturator section is your inner thigh, basically. Okay, so the obturator nerve is inner thigh. Cool. So this is the nerve. So obviously from the lumbar spine, which we'll cover, let's just get rid of that. So we'll cover that when we get to the lumbar spine and we have a look at the lumbar plexus, the group of nerves that arise from that region. And so it travels in front of your sacrum, and then it will go through that obturator foramen. So that's the hole there that we were just looking at. And obviously it's not just a hole. There's stuff in it, and there's a membrane across it, but there's a gap in the membrane, and that gap is where this nerve comes through. Okay, and sometimes the obturator, but the obturator nerve splits into two. So again, we covered that a couple of weeks ago, but we'll go over it again. So, and where it splits into two, sometimes it will pass through the external obturator muscle. Okay, so obturator externus, and you can get some irritation of the obturator nerve because of that relationship. So similar to the piriformis and the sciatic nerve, which we'll touch on hopefully today. So we're going through this region here, and it will pass in front of your pubic region. So where your pubic bone is, it's kind of comes through the hole there. So if I just hold that up again, so it's through that area there, okay, and that's how it accesses your inner thigh. Okay, so through that gap there. Right, let's have a look at the structure then. So there was a slight error on this. So we've got where it splits into two. The obturator nerve then goes anteriorly and posteriorly, so towards the front and towards the back. Okay, and the anterior branch is split up into different types of nerve. And again, we covered this a couple of weeks ago, but just as a recap, so we've got motor nerves which go to the muscle. We've got sensory nerves that come from the skin and supply the sensation from the skin, or detect the sensation from the skin. And we've got articular nerves, which are branches that go to the joints and receive information from the joint to let your body know what's happening with the joint capsule and the environment in and around the joint. Okay, so on the anterior branch, so where it goes towards the front of the inner thigh, we've got four motor nerves, and they supply these muscles here, and we covered these a few weeks ago. So we've got pectineus, adductor brevis means short, so we've got the short adductor longus means long, so long adductor, and then gracilis, okay, which means slender. So we've got those four muscles that are supplied by the front portion of the obturator nerve, and all of those muscles close the legs. Okay, so those are your adductor muscles. Okay, and then the sensory nerve. So this is a bit that supplies the skin. Anything with cutaneous in is to do with the skin. So the obturator cutaneous nerve receives information from the skin, and then sends that information back to your nervous system. Okay, and then the one thing we're missing off there is the articular branch, which on this picture is just here. So it's that one just there, and that's going towards the hip. Okay, so the hip joint receives a articular branch of a nerve, the obturator nerve, and again will send information to your nervous system via that pathway. So before we move on to this one, so if we have a look up here, so this is where it comes from in your lower back. Yeah, so we've got L2 to L4. Exactly the same as the femoral nerve. So the roots are the same, and they then come together. So they all bunch together to form one nerve, and then it splits again. Okay, So where at certain parts of the nerve, we've got different types of pathways. So we've got some that are receiving information and some that are sending information. So in this point here of the nerve, just up here, we will have stuff being received from this branch, so the articular branch. We'll have stuff being received from this branch, the cutaneous branch, and then there's another cutaneous branch around here as well. But also it will send motor signals via these to the muscles. So this bit of the nerve here is mixed. Yeah, so we've got sensory areas and motor areas, and they'll be like passing each other by like a highway. Okay, so from the naked eye, you wouldn't be able to tell. All right, you just wouldn't know which bit's which. But when they get to the nerve root up here, they split off in their different directions to connect to the spinal cord. Okay, and we'll talk about that when we get to that area. But it's important to know, I think, that we've got a mixture of nerves here, and then they branch off into either sensory or motor as you go down. Okay, cool. Hopefully that makes sense. And then we've got this other split in the obturator nerve. So we've got a posterior division. This has got two motor branches and one articular branch. So one go into a joint and two motor. So this one here, the articular branch goes to the hip. And if I move me out of the way, whoop, there we go. This one has got an articular branch that goes to the knee. Okay, so can you see this one here? So as it comes down there, it goes and supplies the knee. There are some other cutaneous nerves that supply the knee as well. So this is the sensation around the knee, okay? And the motor branches are obturator externus, so your external obturator muscle, and then adductor magnus. So magnus just means massive, okay? So the massive adductor muscle. And the adductor magnus has got two nerves supplying it because it has two actions. So, and again, we covered this a couple of weeks ago. So adductor magnus will adduct the legs, so it will bring the legs in together, but it also helps with a bit of hip extension as well. And there are different portions of it that do different things, and they've each got a different nerve supply. Okay, so and yeah, we'll have a look at that when we get to it. Okay, so this is a nice schematic of the nerves. It kind of gets rid of everything and just drills down into the nerve. I can't remember what the book that I got this from. I'll have a look after the session today and I'll post a link to the book because I think it's brilliant. It just kind of breaks everything down into real simple pictures. Okay, and I do love a picture in a video. So we've got L2 to L4, and so these are the coming from the nerve roots. Okay. Then we've got the obturator canal, which is that bit coming through that hole. If I do that one, coming through that hole there, there's a little gap in the obturator membrane. And then after that, it then splits. So we've got an anterior division going towards the front and a posterior division come towards the back. So we've got the obturator externus branch that comes off and supplies that muscle in there, and that's one of your deep hip rotators. Okay, and again, we did a whole session on we called it the rotator cuff, or I called it the rotator cuff of the hip, because you've got all of these muscles that help to maintain the position of the hip, similar to the rotator cuff in the shoulder. Okay, so that's that one. And then if we follow this posterior division down, then we've got another branch, motor branch, that's coming off to adductor magnus. And then this bit here, the adductor hiatus, that is in the adductor magnus muscle. And that we covered on the knee. Okay, so again, if you want to go back over the videos, there's a gap in the adductor magnus muscle where things can pass through from the front of the body to the back of the body. And in particular, the artery, okay, which we'll have a look at the hip part of that artery in these sessions. So that adductor hiatus then goes through that gap, and then we've got an articular twig, love that, to the knee joint. So that will go to the capsule of the knee, and you'll receive information from that nerve about the health of the knee joint. Okay, so going back to what I was saying before, that's sensory. So that information is going this way. So it's going from down here to up there and then into the various nerve roots. This one is motor. So we've got information coming from there down this way. This one's motor as well. So from there down this way. Yeah. So you can see how they're crisscrossing each other in this point here. Yeah. So we've got a mixture of motor and sensory at that point. And then the anterior division, we've got this branch, which is going to the hip, which we were talking about before. So that's the articular branch. A motor branch going to pectineus. Another motor branch going to adductor brevis, which is the short adductor. Adductor longus, which is the long adductor. And then gracilis, which is the one that's most medial, okay, on the inside of your thigh. And then we've got the cutaneous branch to supply the skin on the medial aspect of the thigh. So this one is from the joint. This one is from the joint. This sensory one is from the skin. Okay, so you're receiving information from the skin. So if there's a problem with this nerve, you will lose sensation here. Okay, so this is the skin on the medial aspect of the thigh. So there's your ASIS, and just up there's your kneecap. So this is a front view of a right leg, and that is the patch of skin that the obturator nerve supplies. Okay, so if you have an odd sensation to the inside of your thigh, I mean, there is a bit of crossover from some other nerves as well, but generally that could be an issue with the obturator, the sensory part of the obturator nerve. So anywhere along that branch, as it gets to the skin, so it could be a nerve root issue or some kind of entrapment as it's on its way down. It could be any one of those, but it's the anterior division. Okay, so if you have a look at the pathway, you wouldn't know. Okay, you wouldn't be able to tell. So all we do clinically is test it, and if it's reduced, and they've got some other issues as well, then we'd send that to be checked out. Okay, that's basically it. Well, all we would do is say what our findings are, because there's 100 different reasons why someone would lose sensation in a nerve. And again, we'll look at the pathology once we've looked at the anatomy. Okay, so the sensory distribution obturator nerve is your inner thigh. Okay. And then we've got this branch. Let's get there. There we go. I'll go specifically go into the obturator internus. Okay. Remember that on the last one, a branch coming off of the obturator nerve supplied your obturator externus muscle. This one, internus, has got its own nerve supply, okay? And that's all it does, is go towards this muscle here. So we've got obturator internus and gemelli superior, okay? So it's, sorry to say it's the only thing it does. It does two things. So it's a motor nerve that comes from L5 to S2, so it's a little bit lower down than the obturator, yeah? So it's a completely separate nerve that only supplies these muscles, okay? And so we've got obturator internus and gemelli superior. That's that kind of wraps up your obturator muscles and which one supplies which. So you got obturator nerve supplying the internus, and then this, the externus, and then this one supplying the internus. Okay, so they've got their own specific supply. A little bit lower down, L5S2, and again, testing wise, there's no way you'd be able to isolate these structures to know if there was a problem. You would just pick up some kind of generalized weakness in the rotators of the hip. Okay, so and they would have to go away for further investigation. There's again, we talked about this before, trying to isolate things and say, oh, that problem is being caused by that. It's really, really difficult to do that. And the reason why is because the internus and gemelli superior, the action of those muscles, there's a load of other muscles that do a similar kind of action. So you may lose the motor function of those, but just not know, okay? Because the other things will take over. Okay, cool. Hopefully that was all right. All right, the nerves is always a heavy one. So we've got sciatic nerve next, and this is quite an interesting one because uh, we always think, or I assume so because I hear it quite a lot, that if you have a loss of sensation on the back of the thigh, it's deemed sciatica, and coming from the sciatic nerve. But the sciatic nerve doesn't have any sensory branches on the back of the thigh. It does lower down in the leg, but not on the back of the thigh. So it's quite interesting, I think. So we're going to cover that now. So if we have a look at, yeah, here we go. So we've got 4 motor branches for the sciatic nerve. If I just move me out of the way. So L4 to S3, so it's quite a big area that it covers, and when we come up to the lumbar spine, we'll talk about more what L4 to S3 means and where everything comes from. So it's actually 2 nerves wrapped into one, and sometimes it splits really high, so it will split up in the pelvis area. Sometimes it splits really low down by the knee. In all of the textbooks that you see, it will divide just above the back of the knee. And from doing a lot of dissections over the years, I would say that is the that's the exception rather than the norm. Usually we see it split a lot higher, and quite often up around the area of the hip rotator, so just around the gluteal region. And you'll have a separate tibial and peroneal nerve, or fibular nerve, all the way down the back of the thigh. So you'll have basically 2 sciatic nerves going all the way down, and that's quite common. Okay, so yeah, it's again, anatomy is not always what it looks like in the textbooks. So we've got 4 motor branches of the sciatic nerve. Okay, so we've got biceps femoris, which is one of your hamstrings, semimembranosus, again, another hamstring, tendinosus, which is another hamstring, and then your adductor magnus. And remember when I said that adductor magnus has got a dual nerve supply. So you've got a supply coming from the obturator nerve and also a supply coming from the sciatic nerve. So the obturator branch will activate the adductor motion of that muscle, and the sciatic branch, that motor branch, will do the extension component of that muscle. So it's got a dual nerve supply, it does 2 different things. It's often called the 5th hamstring. And you go, why is it the 5th? Because we've only got 3. Well, biceps femoris is 2. Okay, so you got 2 heads on the biceps femoris, semimembranosus, semitendinosus, and adductor magnus. So those are your 5 hamstrings, if you like. Okay, then we've got the sensory branches. There are none in the thigh. All right, so that bit from the kind of crease of your buttock to the back of the knee, the sciatic nerve does not provide any kind of sensory feedback from that area. That they're supplied by different nerves, not the sciatic nerve. So if you have a loss of sensation on the back of the thigh, it is not the sciatic nerve. Usually you feel odd sensations in your shin and in your foot, and that is likely to be sciatic nerve. Okay, and again, we covered that when we looked at the ankle and the knee. All right, so it provides sensation to the leg when it divides. It depends on where it divides. So, but it was provide sensation to the leg, which is below the knee. Okay, so the leg is below the knee, the thigh is from the hip to the knee joint. So no sensory component in the thigh, but there is in the leg for the sciatic nerve. Cool. Okay. This is really interesting, I think, well, for me anyway. These are the different variations of the sciatic nerve. It's called the Beaton and Anson classification from these authors, Rowan Edmonds from 2018. And they categorize the sciatic nerve at around the piriformis area into 6 specific categories. And they are these. So we've got type A. This is the most common. So this is where the sciatic nerve emerges below the piriformis muscle. Okay, so it just goes underneath it and everybody's happy. Type B is where you get a branch that pierces the piriformis, and then the other branch goes underneath it. So it's where it's split before the piriformis, and a branch will go through it. Okay. Then we've got one that goes over the top of piriformis, one underneath. This one here, where both are still wrapped together. Okay, so they haven't split at this point, and the single sciatic nerve goes through the piriformis. This one here, where the top part goes over and the bottom part goes through, and then this where the whole thing goes over. So those are the common variations of the sciatic nerve around the piriformis. Okay, and again, looking at a patient, you would not be able to know what is going on. Okay, so they may kind of constantly have like issues around the area, and or they may completely adapt and they have no issues at all, and we can't really tell whether it's because of the sciatic nerve passing through or not. We have no idea, and we're just making a guess basically, because some people can live with this absolutely fine, no problem at all, because they just adapt. Okay, so it can be a problem or it might not be. So yeah, there you go. But what it does question is sometimes the sensation people get when you do manual therapy treatment. So if you're sticking your elbow into someone's piriformis, then it could help, or it may hinder, depending on the type of anatomy there is around that region. Possibly, don't know. Okay, so there's been no studies done certainly on that, but it's just something to bear in mind when you're treating this region, and especially if you're using electroacupuncture or acupuncture in general, and you're aiming for the piriformis, because if you've got a sciatic nerve that's going through it, you could jab the sciatic nerve with a needle. Okay, and especially if you're using electroacupuncture. So yeah, it's just, again, does it cause a problem? Again, there's been no studies done on it, but it's something that could potentially cause you neurological symptoms, and you would have to adapt your treatment. Okay, so again, it's just something to be aware of, that if someone's getting referred pain, then it's yeah, it could be that. So yeah, just bear that in mind when you're doing that. Okay, so I'm going to go through this and then we'll have a look at a video. So we've got posterior cutaneous nerve of the thigh. This is where the back of your thigh gets its sensation from. So not the sciatic nerve, okay? Remember we said that before, but this one. So if we have a look here, there we go. So we've got, so what about skin sensation in the back of the thigh? Because obviously it's not sciatic nerve that does that. So we've got 3 branches. Yeah, we've got from S1 to S3, cutaneous branch, which goes to your posterior thigh. So this one here covers all that area there, okay? And it's coming from your sacrum, yeah? Gluteal branch, there's a specific supply to the gluteal fold, okay? So that area. And then the perineal branch, which goes to the scrotum and the labia majora. So loss of sensation around those areas isn't coming from the sciatic nerve. It's coming from the posterior cutaneous nerve of the thigh. Okay, so again, useful information, I think, if you do neurological testing. Pelvic pain can masquerade as sciatica due to the shared parasympathetic pathways at S2, S3. Okay, so it's it looks like sciatica, but because you've got pain down the back of the leg or odd sensation down the back of the leg, but isn't to do with the sciatic nerve. Okay, right. Let's have a look at this. We've been warbling on too much. Okay, so this is your sciatic nerve. This is what we were just looking at. Always get very few questions when we do the nerves. Everyone's heads are hurting. If you do have any questions, pop them in the chat. Right, okay, let's just pause that there. So, bit of an orientation then. So there's your ASIS at the top there. There's your iliac crest. So this here is a right leg, and we're looking at a front view, anterior view of a right leg. That there is your pubic symphysis. And then coming across here, you've got the inguinal or inguinal ligament coming across there. So this nerve we looked at a couple of weeks ago, the femoral nerve that passes to the front of the thigh. What we're now having a look at is this plexus here. So can you see all those branches coming out there? Yeah, so that's what we're interested in right now. So there's your lumbar vertebra. And just pause that there. So here we've got branch from L4, branch from L5, and these are the spaces in between the vertebra. Okay, S1, so sacrum 1, so L means lumbar, S means sacrum, sacrum 2, sacrum 3. Okay, and can you see that's basically what a nerve looks like. And they obviously they look yellow in the textbooks, but not in real life. They're a bit opaque. And then can you see that there? That's where they've all joined together. Okay, so similar to what I was saying before about the obturator, where from L2 to L4. So we've got branches coming out of there, and then they all join together to form one, and then they split again. Okay, and go off wherever they need to go. Exactly the same with this. Okay, and plexus means plait. Okay, like plaiting your hair. So this is a plait of nerves. Yeah. Okay, let's have a look at this. So this hole here, let me just pause that video just there. See if I can find it on here. So that hole, can you see that bit there? Yeah, that bit on the back of the pelvis, that is the greater sciatic notch. That bit there. And that is that. Okay, so the sciatic nerve goes through that greater sciatic notch. And yet they are really big. So the sciatic nerve, when it emerges as one, is it's probably about the size of your thumb. Okay, it's pretty the thickness of your thumb. It's a pretty chunky nerve. There's the piriformis tucked behind it there, which everybody always bangs on about. And then there's your sciatic nerve just there. Okay, so superior gluteal nerve is a branch that comes off. We'll talk about that in a sec, but there's the foramen. Okay, so that was the bit I just showed you on the model. And then, so it comes from the front, so those areas on the front, and then it will come around the back. So there's the glute max. So take glute max off, and this is where it comes through. So there's your piriformis. Let me just pause that. So there's the piriformis there. So the sciatic nerve has started on the front of the body, coming out there. They've then joined together, and then it comes backwards through that greater sciatic notch, and then down the back of the thigh. Okay, so that is it there. And this one looks as if it's split around about there. So let's have a look at this. Yeah, so there's your sciatic nerve there. There it is. And it does look as if it might have a bit of a split in there. Yeah, quadratus femoris is there. Your reductor magnus is there. This is the long head of the biceps. So your sciatic nerve goes through the two heads of your bicep femoris. So you've got a short head and a long head, and then they both converge together. So the long head comes from your ischial tuberosity. Short head comes from the back of the femur, so the linea aspera, and then they both join together to attach onto the tibia. Or onto the fibular head. So the sciatic nerve comes through those two muscles. All right. So quite often you'll get like nerve tension or the feeling of tightness in the hamstrings around the biceps femoris, and it could potentially be some kind of restriction of the sciatic nerve here. Okay, and you get what's called a mechanosensitivity. So the nerve gets irritated, basically. So that's the nerve just there. There it is again. And then these are the muscles supplied by it. So semimembranosus, semitendinosus, so your hamstring muscles. Also biceps femoris, so your two heads of biceps femoris, and then the back of the adductor magnus. Just go back there a sec. Yeah, so semimem, semitend, biceps femoris, which is here. So obviously the two heads of that. And then the posterior aspect of adductor magnus. So that's the bit of adductor magnus that does hip extension. Okay, so you've got a bit that does adduction and then a bit that does extension. And the bit that does extension supplied by your sciatic nerve. Obviously, that then travels down to the leg and then supplies skin sensation and also motor function for some of the muscles in the lower leg. We've covered that on the other videos, so we're just focusing on the hip and pelvis for now. Okay, cool. And then if we have a look at this one, so this is the obturator nerve, so the one we were looking at the very beginning. So this is L2 to L4, same as your femoral. Okay, so same kind of view as before. So that was the view of your femoral nerve, and then there's the obturator just there. So now you've had a look at the last one. You can see where everything all comes out of the lumbar spine and the sacrum, and then divides off into different sections. So this bit here, that one there, that's your femoral nerve. This one here is your obturator nerve, so that's going towards your inner thigh. And then this one here, this needs to get to the back because this is the sciatic nerve. So it goes through that hole there and then goes towards the back. So they're all coming from a similar kind of area, and then they bunch together, and then they all go off in their different directions and go through various different holes in the bony anatomy to get to the muscles in the skin that they need to supply. Okay, so let's have a look at this obturator and where it goes through. And you'll see that obturator membrane as well in a sec. In fact, you can see it from the back there. So where the obturator nerve is coming through there, can you see it it's just piercing that area there? And then that'll go through and supply your inner thigh. You got a better view of it in a second. Here we go. So this area here, this is where the obturator foramen is. So hopefully there we go. So let's just pause that there. So this is the nerve coming through there. Yeah. That hole there, that one there is that one just there. Okay. So the nerves come from here. It's gone down and then through there. And then it's aiming towards where you can see straight away, it's going towards those adductor muscles there, but it's split. So you got the anterior and posterior divisions just there. Excuse me. So there's your obturator externus through the obturator foramen just there. That looks like sartorius just there. Here we go, and you can see where they attach. So that's basically what they do is they just kind of stop on a muscle, and then that's how it gets its supply. So adductor brevis, longus, pectineus, and then the anterior portion of adductor magnus, which is the big adductor muscle. Okay. That's a really good question. Yeah, so the nerves all seem to be different sizes. Let me just pause that there. Is this because they supply more or less structures? Yep, that's exactly it. Yeah, so the bigger the muscle, the bigger the area that they cover, the bigger they're going to be, because they're going to need more neurons to do their job. Yeah, and also the ones that supply the lowest part of the body, they're usually the chunkier or the furthest away. They're usually the chunkiest because they've got branches going off onto different muscle. So if we think about the sciatic nerve, that is two in one. So you've got all of the tibial nerve branches, which we looked at in the foot and ankle, and all of the peroneal or fibular nerve branches as well that supply all of the muscles around the foot and the skin sensation. So you've got loads of information being sent and received by that sciatic nerve. Plus, it also supplies the motor to those four hamstring muscles and the adductor magnus as well. So it's got a lot of roads. It's got a lot of a road network going back and forth. So if you think of it like the sciatic nerve needs a big motorway because there's loads of stuff going back and forth, the areas that it goes to. But then the obturator is like a little A road because it's only going to a couple of little things. So it doesn't need to be as big. Okay, hopefully that makes sense. Difference between the obturator and femoral nerve. Unable to picture them together. Right, let's just go back here. So there is the femoral. That one there is a slightly thicker nerve than the obturator, which is this one, because the femoral nerve supplies really big muscles, so the quad muscles, and they generate a lot of force. So they'll have bigger, more motor units, bigger motor neurons. So yeah, that's the difference between the two. So you got femoral just here, and then obturator here. Okay, but that's the femoral there by the looks. I think that's the femoral artery. Yeah. So yeah, obturator quite thin, and then the femoral a bit thicker. Just again from the example that I gave before, the femoral nerve supplies a lot more, and also receives information from a lot of the skin over the front of the thigh as well. Okay, hopefully that's helped, Martin. Right, what time is it? Cool, I think. Let me just see where we are on the PowerPoints. Yeah, perfect. I think we'll leave it there. So this is something to have a look at for next week. Yeah, I can say that usually the nerves take a bit of time to get through. So hopefully done by next week with these. So we've got lateral cutaneous nerve of the thigh. Now there's a real specific condition that that you can get. That again, people mistake for being a femoral nerve problem, and yeah, so the lateral cutaneous nerve of the thigh, all it does is supply skin sensation to the outside of the thigh. Have a little bit of a look on this. So as a just if you've got a bit of time this week, have a look at some of the reasons why this may cause you some jip, basically. Okay, and what someone might present with if they've got a compression of the lateral cutaneous nerve of the thigh. So how that compression happens and what kind of symptoms that they get. Okay, I'll tell you next week, but have a look this week. Okay, and just do a little bit of homework. Cool. That went pretty quick. I will see you next Monday, 10 o'clock. Hopefully that was all okay. If you've got any questions about this session, drop them in the group and then I can answer them next week or and throughout the week as well. Okay, cool. See you next week.